Hello, dear friends. This is a case of a 86-year-old woman who presented with classical symptoms of severe, acute onset of severe chest pain radiating to back and epigastric pain, and further evaluation with CT aortogram was performed to rule out aortic dissection. First of all, let's have a look and scroll the images up and down so you will make your first impression. Here is the level of the aortic arch and the three branches of the aortic arch. We will discuss the findings. Just have a look and let's go down. As you can see, there is a dissection type A, which is extended from the aortic valve down to the distal abdominal aorta and somewhere here. Okay, let's go back and let's discuss the findings now. First of all, there is hyperdense fluid in the pericardium, and that means that there is hemopericardium. And how this happens? Hemopericardium is most often due to rupture of a type A aortic dissection into the pericardium, as in this case. So there is a rupture of the ascending aorta somewhere, hence the appearance is hyperdense fluid. The second interesting finding is that there is hyperdense fluid between the ascending aorta and the right side of the pulmonary trunk, extending to the right main pulmonary artery, here and there. Hyperdensity. So that means that there is an intramural hematoma, extension of blood to the pulmonary artery. And how this happens? It happens again because of a rupture of the ascending aorta, and the rupture usually is between the ascending aorta and the aortic root. And how this happens? Because both the vessels, the ascending aorta and the pulmonary tract, have a common adventitia. Common adventitia means a common outer layer of fibrous connective tissue that surrounds both vessels, the ascending aorta and the pulmonary artery. As for the first complication, the hemopericardium, this, if progresses, can cause a cardiac tamponade. Now, as for the second complication, the extension of the hematoma to the pulmonary artery, this can lead to a significant stenosis of the pulmonary artery. Like in this case, this is another case, I give you an example. So, as for this finding is a very rare complication, and we must keep it in mind when we see a case with a type A aortic dissection. Now, as for the rest of the findings, let's have a look. There are some additional interesting findings here. We can see the true lumen and the false lumen of the aortic dissection. Another interesting point is that we have to check the coronary arteries of the heart. Fortunately for this patient, both the right coronary artery and the left coronary artery arising from the true lumen so they show sufficient patents. However, there are heavy wall calcifications. Another finding is that the dissection is extended to the brachiocephalic artery, as you can see here, and mildly to the right common carotid artery as well. Now let's go a little further down and check the rest of the vessels. As you can see, here is the true lumen and the false lumen. The first vessel we will see is the celiac artery, and it is here, and fortunately arises from the true lumen, so it is patent. Let's go a little further down. The next vessel is the SMA, the superior mesenteric artery, and unfortunately the dissection is extended to the superior mesenteric artery significantly. There is a near occlusion. At this point, there is it is the right renal artery, which is patent because it arises from the true lumen as well. So the right kidney opacifies well, in contrary to the left kidney, which shows no opacification because the left renal artery arises from the false lumen. And the same happens to the inferior mesenteric artery, which is here. It's very ill defined and shows no opacification. Dear friends, thank you for watching this interesting video. If you like my videos, you can consider to subscribe to my channel so you will be notified the next time I will upload a new video to my channel. Thank you and see you the next time soon.